All right, our next speaker is Dr. Giles Peak. He's a professor of surgery and pediatrics at the University of Florida at Shands Children's Hospital. I had the pleasure of visiting his program just a few months ago, and I was very impressed with some of the practices in anesthesia, surgery, and perfusion. So it was really instructive being there and having the pleasure of watching a case. And today he's going to be talking to us about nitric oxide and ECMO.
Thanks very much. I describe myself as an ECMologist and a congenital heart surgeon. If you don't know what an ECMologist is, then I suggest you look at your programs and see whether you actually have one or not. And if you don't, then I'm sure your life will be easier if you do. And I'm sure many of you would fulfill that description yourselves. So SNO is obviously nitric oxide in the sweep, as distinct from INO. Some of the adult ECMologists will call it DNO, but D is used for lots of different things like delivery, and so I prefer SNO. It's also the ELSO standard to describe the sweep as F, as S, so it's FSO2, SNO, and so forth. I have no disclosures financially, but I always start by saying that my main disclosure is that ECMO is a team game, and that the presence of Esperanza, the first successful neonatal ECMO patient, with her doctor, Dr. Bartlett, who had his 86th birthday this week, in the middle of this slide is not a coincidence. So let's start with a bit of history. These two guys are very important. Ted Colombo realized that separating the blood and gas phases of in the oxygenator was really important if we wanted to do prolonged extracorporeal circulation. So he basically built a machine to make sheets of silicon rubber and then made these hand-rolled oxygenators, which became SciMed ECMO oxygenators. Warren Zapol was his lab fellow, anesthesiologist, and he conducted the 1970s NIH ECMO study, and then also went on to describe the use of inhaled nitric oxide and owned the patent on that, and was extraordinarily rich as a result. And they've both left us in the last couple of years. This is the first successful adult ECMO patient, 1971. Marc de Laval, who's one of the people that taught me, also sadly left us, was actually part of the team that treated this patient. So Esperanza, the first ECMO patient, neonate, 1975, she also had her birthday recently, and she's now 50 years old, 9 years younger than me, and continues to walk around perfectly healthily with a ligated carotid artery and with a small piece of silicon rubber in her left pulmonary artery, the lower lobe, and seems to be perfectly okay on that. So we're all used to running patients on ECMO, and various different bits of technology have made that easier over time. So we went from roller pumps with massive 4,500 square centimeter silicon lungs in parallel, because we had to use two to provide adequate gas exchange. We abandoned the SciMed lungs, and now we have PMP, solid fiber oxygenators. Anyone still using polypropylene microporous oxygenators? It's amazing, that, wasn't it, that everybody thought that was okay. Of course, widespread use of centrifugal pumps. You'll notice the circuit in the top left of this screen doesn't have millions of bridges and Galveston diamonds and all kinds of stuff. And in fact, our current circuit has even fewer connectors than this. So all of these bits of technology have led to improvement in the blood surface interaction, and less clotting. You can see that circuit in the middle there with the bladder box, with the bladder in the circuit, and a massive clot that's been removed. And also lots of interest in using direct thrombin inhibitors instead of heparin. And that's quite important, and I'm going to talk a little bit about that as we go. So this talk is about nitric oxide. This is an old picture from University of Leicester, before we had to pay for nitric oxide. So we used to get it free from British Oxygen, and it came in pink cylinders, and we had to make our own nitric machine. That thing next to it is a Sechrist ventilator, which some of you may remember, and still remains my favorite ventilator. Now, I'm going to go over some science here, so pay attention. So this is how nitric oxide works. It does all kinds of important stuff. Now, that stuff is actually fundamental to the whole conduct of life in the human body, and obviously in animals as well. But nitric is a fundamental mediator. It basically makes your endothelium allow blood past it. It does all kinds of anti-inflammatory things, and it's a selective pulmonary vasodilator as well to boot. And this is very important because coagulation and inflammation are basically two legs of the same process. And so, you know, phylogenetically, if you look at simpler and simpler organisms, they have these kind of combined systems. And so seeing it as two separate systems is an intellectual construct that I don't think is helpful. So limiting both coagulation and inflammation are important parts of the whole thing. And the platelets are important inflammatory mediators as well as parts of the clotting system. And you can see here all of the various receptors on the platelets that we've heard about already today. And we've heard that heparin activates platelets. So giving heparin, even if you don't have immune-mediated HIT, heparin is still going to activate your platelets. So avoiding heparin, I think, is important part of keeping our circuit flowing. Now, before I did the CSER trial, I actually started looking at various blood surface interactions and also looking at mechanical properties of ECMO tubing and roller pumps. So that was really helpful, knowing a lot about roller pumps in the current ECMO arena when almost nobody uses a roller pump. But we did some interesting work, and so it's nice to go full circle and come back to that now. So various people over the years have thought about limiting blood surface interaction in ECMO circuits, and there's all kinds of work about coating, and Ludwig von Segersser was a big worker in this area. Dr. Bartlett's lab and Gail Anich worked very hard to produce nitric oxide coating, nitric oxide donor coatings that could be added to the circuit. And there's been various successful circuit coatings used, some of which are based on heparin, phosphatidylserine, all kinds of things. The obvious thing about the oxygenator is it's got blood on one side of it and it's got gas on the other, which means that you can add things to the sweet gas really easily. So nitric oxide is obviously a very easy thing to add to the sweet gas. I've been doing that routinely for about the last 4 or 5 years, and intermittently before that. And we've, if you want some further reading, we've written this up, our experience, and also some kind of basic science stuff in the Perfusion Journal, which I commend to you. And it gives some of the idea behind what we're doing. This is our first series of children receiving nitric oxide in the sweet gas, and we compared it to the previous 30 patients that we did before we started adding nitric oxide to the sweet gas. And they're just all comers, so a bit of respiratory, bit of cardiac, and really this is just to show safety, which I think it does. Now, I was looking at this again this morning in preparation for this talk, and I suddenly had a realization that we made a massive cock-up, which is an English expression to demonstrate a tactical mistake. If you look at the ECMO circuit changes, which has a p-value of 1, so in other words, no difference, there's 4 in the nitric group and 6 in the no nitric group. But look at the runtime. 339 hours is the median duration of ECMO in the nitric group versus 166. So I'm going to reanalyze this, and I think if you do circuit changes per 100 hours of ECMO, I think there will be a significant difference. And we're in the process of writing up our adult patients that received SNO at the same time. Now, I'm very thankful to Dr. Matke, who's from the University of Queensland, who presented this work at EuroELSO last week, and he's now one of our collaborators, he could say that we're one of his collaborators, and he's very graciously shared these slides with me. So this is the NECTAR trial, and this is the team, Adrian is an intensivist at the Children's Hospital in University of Queensland. And this is a review of the historical literature, it's not terribly exciting, but nitric oxide probably reduces platelet consumption and platelet activation during ECMO, 1996. 1998 might reduce platelet consumption on bypass without having any effect on platelet function as reflected in the preserved aggregation response in their patient. That's important. This is in effect local to the oxygenator, and that's also true of the physiologic effect. So when we're running SNO on the oxygenator, we can take it off. We can stop it cold and take the patient for a walk, take the patient down to CT scan. We don't need to sort of do the stuff you do with inhaled nitric oxide, where you wean it very slowly. In children younger than 2 years undergoing bypass, the use of nitric oxide did not significantly affect the number of ventilator-free days. These findings do not support the use of nitric oxide delivered into the bypass oxygenator during heart surgery. But bypass is a short-lived process, so it's really important, obviously, to do the best bypass we can, but maybe the duration of bypass isn't enough to see any benefit from nitric oxide. Equally, what's the right dose? More recently, no real effect. No difference in survival, but fewer circuit changes, lower blood product use, lower risk neuroinjury for patients that had bypass before they had ECMO. So a lot of this work's been done in Australia, where adding nitric to the sweet gas has been investigated quite extensively. So the NECTAR trial, which is in press but was reported at EuroELSO last week, aims to answer some of these questions. And I think that it answered the first 2 of these, or maybe even the first 1 of these questions adequately, but I would suggest that it wasn't powered to detect the other ones. And Adrian says that himself. So it's non-blinded, open label study, randomized, and they tried to get 50 patients, and it was not powered for efficacy. Single center, because nobody else was interested. This is their ECMO setup, rotaflow and quadrox for small patients, CardioHelp for big patients, using heparin. I looked at my calendar this morning and I noticed it was 2025, so that tells you all you need to know about heparin. So I think that does make a difference. And they're using 20 parts of nitric. Now, part of the problem with running nitric in the sweep is that the nitric machine produces has a minimum bias flow. So that can dilute your FSO2 quite significantly at high flow rates. So having a machine that delivers with a low bias flow is important. So the ionotherapeutics system has a bias flow of about 2 liters, so they didn't use that. This is our setup that we described for using the same device. They didn't use that. They had this Sokinox system, which is not available in the US, I don't think, yet. But it doesn't really matter which system you use as long as you understand what the issues are. This is their setup, and you basically just stick it in the sweep gas and analyze it before it goes into the oxygenator. It's pretty straightforward. The sampling volume and the bias flow is important to know what those are versus how much your sweep gas is. The statistics are essentially dictated by the fact that it wasn't powered to detect an outcome difference. So this is the recruitment. 56 patients actually were eligible for inclusion, and 53 underwent randomization. And so they put 25 in the nitric arm and 28 in the control arm. And so already you've got a fairly small study, which doesn't minimize the importance of it, because I think it's a really good piece of work. But it does, I think, show one of the weaknesses of this study, as Adrian will say himself. So you've got 9 and 12 neonates, 19 and 13 pediatric patients, and a spread of diagnoses. And so I think the amount of inflammation is different between these patient groups, and I think that makes a difference. And I think also in patients that have had surgery and maybe bleeding and maybe have the anticoagulation turned off for periods of time, that's also an important factor. So I think the congenital heart surgery patients are also a different kettle of fish. So also a difference between VV and VA ECMO, which I think is also important, and different circuits as well. So 18 and 21 in the rotaflow with the small quadrox, and then some with the MEDOS, and then some with the CardioHelp. So a whole mishmash of different patients. Anticoagulation with heparin, and this is the safety, which I think this study does go some way to answering. So really very little problems with high methemoglobin, and a big difference in the groups in terms of the need for circuit replacement, with much longer rate in the standard care versus nitric oxide. And again, I think that almost certainly comes down to case selection and what the groups are, rather than anything else. No difference in survival, and no difference in length of stay, really. No real difference in blood use or anything. So really quite disappointing, but not really surprising, given the study design. So the conclusion is that you can give nitric into the circuit safely, but it really doesn't prove any clinical efficacy or clinical inefficacy as yet. Now, these are very important questions that Adrian raises. 20 parts per million is the dose that I use, but should we give 40 or 80? Who knows? So I think that's the study that we need to do to start with. We know that nitric oxide has this physiologic effect on the pulmonary vascular resistance when it's given into the lungs. We know it reduces platelet activation because that's been shown in the lab. But maybe it's having a physicochemical effect. Maybe there's actually nitric oxide gas actually sitting on the membrane and keeping the elements of the blood away from the EMP. So that's an interesting thought. They also looked at the cytokines and things, which is all very exciting, and that's going to be out fairly soon. So if you want to email Adrian, he's a jolly nice chap, and that's his email address. And I think if you are working in the nitric area, I would suggest that you try and collaborate with Adrian and with ourselves. Now, artificial placenta. So this is George Mikulaiska's group at the University of Michigan. And they did a lab study where they ran 100 parts of nitric in the sweet gas as their only anticoagulant for several days in an artificial placenta model. So, and had really clean looking circuits afterwards. So I think the dose is the massively important thing to look at. So now I'm going to switch from science, because mankind has only been alive for 300,000 years, and actually we still intrinsically marvel at the eclipse and are surprised when the sun comes out again afterwards, and we love to tell stories around the campfire. Yes. So I'm going to tell you a story. So this is a 4-month-old girl that we looked after at UF, who presented with RSV and multibacterial necrotizing pneumonia. She went to an outside hospital, not far from here actually, intubated on day 8 of illness, and this hospital did not have an ECMO service, but the surgeons there, pediatric surgeons, knew how to cannulate. So we sent our ECMO coordinator and a circuit down there, and she was on the verge of cardiac arrest, and they put her on successfully. And then we brought her straight back to UF. And this is a CT scan initially. See the blobs of MRSA in the lung? That's a technical radiological term. So there she is, VA through the neck, standard cannulation. On day 14, I converted her to VV double lumen because the heart had recovered. And this is slightly out of order because we didn't trach her until after we'd done that, but the trach's on this X-ray. And that's what her lungs look like around that kind of time. So pretty solid. She had no real measurable lung function for about 3 months. On day 108 of ECMO, she'd grown significantly and had outgrown the double lumen cannula, so I converted her to VV multi-site. And you can see these massive air spaces there, but little islands of residual lung tissue. And those gradually improved.
Go, Abby, go!
We taught her to walk on ECMO.
I know. There's no mirror, so
I can't see myself.
And she had her birthday party on ECMO, and that's Marco next to her, who was bridging to lung transplant. He's also a long-term survivor. Now, this prolonged ECMO course with waking her up, nutrition, mobilization and things, one of the important things that we did was we tried to minimize the amount of circuit changes. So I ran her for 5 months on a single oxygenator, single pump. I think somebody said that the CentriMag was a short-term device, so that CentriMag ran for 5 months. It was okay. Now, the only reason I took the membrane off was because the housing cracked and it started dripping. Now, fortunately, this was during the trial off. I did a 3-day trial off. So I just cut the membrane out and ran the trial off just with a loop of tubing. And it turned out that actually we then decannulated her on her birthday, on her first birthday. I took the membrane and I washed it out, and then I sent it to my friend Andrew Paczynski at Arriva in San Antonio. He has a lab looking at membranes, amongst other things. This is one of his oxygenators after 72 hours of heparinized ECMO in a swine model, and you can see what it looks like. And you know, if you think about that, you know, that's probably pretty much what you expect in most ECMO oxygenators. This is Aubrey's oxygenator after 5 months. Bivalirudin, 20 parts of nitric in the suite. So by day 42 post-ECMO, we got her down to room air. We took the trach out, and we sent her home after 289 days in hospital at UF. And her total duration of care was 301 days. And the lung has come up nicely. What do you think? So what do I think about nitric oxide? Well, I believe it prolongs the membrane life. I believe that it reduces the inflammatory response to ECMO. And I think both of these things may have an effect on survival, particularly in complicated, very inflamed patients like Aubrey. Clearly, it needs more study. I think the dose response thing is the most important question.
Look at that big girl.
Interestingly, she's learning to speak more coherently now. And remember, she spent 8 months surrounded by ECMO specialists. Her first coherent word is shit. And I have a video of her saying that, but I didn't want to put that. So just when you're sitting the pump, just to remember that the kids are listening. Thank you very much.
Brilliant conclusion, Dr. Peak. I love that. Do we have any questions in the audience?
Hi, we just started using Nitric in our circuits as well, and I know. And it's been a pretty seamless transition and easy for us. Our respiratory team has been great. We're using 20 parts, and one thought process I have is, so far our standard is going to be that we put our neonates under 5 kilos on at 20 parts with that high sweep, and then we keep them on until the duration of support. For our patients that are above that, we're going to keep them on until we get therapeutic and then take it off. So I'm sort of curious about any toxicity that you would think might happen on the neonates with that high of a sweep and delivery, as well as what you think about how we might better our protocol.
That's a great question. So I think the problem with neonates really is that the bias flow may be too high depending on which one you're using. So then you just have to add CO2, because clearly blowing off the CO2 is at least as dangerous as hyperoxia. And so that's what we do. We just run CO2 when we have to do that. With the Virotech system, the bias flow is lower, so it's easier. But we run it the whole time throughout the ECMO course in all patients of all sizes. So that's a very good point. Please give Mohammed my best wishes.
So I've got a question, and it's a genuine one because I don't really know. What is the sort of, is there any difference if you were to do a nitric oxide versus a SMP, which is a nitric oxide donator? You know, is there a sort of fundamental difference? Do you reckon there could be similar effects or not really?
I think that I would imagine that the effects would be very similar. I think the thing about the nitric in the sweep is that it's in the gas phase, so you know that is intrinsically straightforward. I grew up using isoflurane in the membrane as sedation, like you do on pump, and you can do that with silicon, but you can't with PMP, as you know. Anyone who's tried to run volatile on PMP and the patient wakes up. So the idea of putting something in the sweep is very obvious to me, but perhaps not to more modern generation of ECMologists. But of course, perfusionists, your ISO's on or SIBO's on while you're on bypass, so it's a very obvious thing. I think that nitric oxide donors coating on circuits is probably the long-term solution, but I think we're a long way away from that.
And I suppose the follow-up question to that is that I suppose we need to look at kind of the combination effects. So actually using nitric on the ECMO circuit and also running SMP from the point of view of minimizing the inflammatory effects within the body, not just on the circuit, which probably will help.
Yeah, absolutely agree. One thing I forgot to mention is Zasha is leading up our Snoopy group with my help. Snoopy for obviously sweet nitric oxide. And this is some tethered liquid perfluorocarbon stuff that she did with an LSAT grant last year. If you're interested, get in touch.
Thank you very much. That concludes our pediatric session. Please join us for. Thank you, Dr.